7-1 in medic 6. You're seeing a 74-year-old male, shortness of breath.
Crush injuries occur as a result of prolonged continuous pressure on large muscles. Victims who are trapped and injured from structural collapses during natural disasters such as earthquakes, hurricanes, or tornadoes will likely have crush injuries. These injuries are also common in military settings and occasionally encountered in patients involved in vehicle entrapments, trench collapses, or in other industrial situations.
The prevalence of crush injury is significant. A lot of folks have seen data coming out of military operations, for instance, and that there is a significant amount there. But it's more of a domestic concern than many people may imagine. For instance, in an earthquake situation, anywhere from 3 to 20% of the survivors in an earthquake will have some sort of crush injury that needs to be addressed. Take building collapses, which are a fairly frequent domestic occurrence in urban areas or throughout the country. In these situations, 40% can have a crush type injury in those. Couple that with industrial applications, where people get caught in machinery. All of these create crush injuries, which require, while in our sense the treatment might not be, there might not be a specific rapid treatment to fix these things in the field, not recognizing that you have a crush injury can be significant, not just to loss of limb, but also to loss of life.
A crush injury can result in crush injury syndrome or compartment syndrome. These are further complications from the original injury. They have different processes, but very similar pathophysiology. In crush injury syndrome, the initial injury site involves a large muscle mass with prolonged compression and compromised blood circulation. Compartment syndrome is a condition that occurs within the muscle compartments surrounding the injury site. The fibrous tissue that surrounds these compartments does not stretch. This causes further swelling and additional injury to muscles, nerves, and blood vessels.
But it could also be due to a closed injury with a broken bone that causes a great deal of bleeding within a compartment, and hence the name compartment syndrome. What happens here is you've got the layers of tissues in the body, muscle, fascia, etc., that creates these spaces or compartments. And what happens when blood in a closed space like that begins to expand, it begins to separate muscle from fascia. And as that happens, it's going to impair and take apart the process that allows circulation to the muscle and out of the muscle. And so we end up with the potential to lose muscle mass and can become a type of injury that could cause the amputation of the extremity.
John! Hey, lay still. I'll go get help.
Usually, one of three mechanisms are responsible for muscle cell death. The least common is the immediate rupture of the muscle cells from the force of the MOI. The second cause of muscle cell death is the direct pressure on the cells, where blood is prevented from flowing in the muscle, which results in ischemia. And the third cause, vascular compromise. This is where the force of the injury compresses large vessels and prevents blood supply to the muscle tissue.
Go check and grab the wheel chock. We'll chock this with one of the wheel chocks on the rig. So I don't want to move anything until we get him stabilized, and then we're gonna figure out what's going on.
Damaged muscle tissue produces and releases many toxins. The longer the victim is trapped, the more toxins are built up. The crushing force impedes local vascular flow and prevents the accumulating toxins from reaching the central circulation. However, once the force is released, the toxins enter into the circulatory system and can damage many organs.
So we got these stabilized here. I want you guys to get him checked out, and then we'll figure out how we're going to extricate these off of him.
Specifically with crush syndrome, what you're looking at is a patient who has significant damage to muscle because of the crush injury itself. And when this occurs, it causes the release of myoglobin, which is normally it's a good thing for you. It helps to store oxygen in muscle cells. And potassium, also generally a good thing. It helps electrical conduction in our body and helps us survive. But when you destroy muscle under great pressure and you're entrapped, these are released and that they're no longer good things, they become toxins. And when the victim is released from the entrapment or the crushing injury, effectively when circulation reopens to the injured area, in effect you are giving a bolus of toxins to the person. The myoglobin becomes hazardous, can create problems in the kidneys, and even in many cases, if untreated, can cause renal failure, which is a significant problem for those patients. The release of potassium in large quantities like that can also create life-threatening arrhythmias.
Early recognition of potential crush injury is imperative. As always, rescuer safety is your first priority. Make sure that the scene has been secured and all hazards addressed before you enter or begin any patient care. Quickly assess the scene. If there is a potential for crush injury based on the MOI, medical interventions should be started prior to any extrication efforts. As you deliver medical treatment, communicate and coordinate all action with rescue personnel. Treatments that are provided early can help prevent renal and cardiac complications.
John, I'm going to put this around your face, okay?
You can get off my leg.
Have you breathe into
We're working
it.
on that. Oh, man.
We're going to be moving this one here shortly. So I want to make sure that we're not going to be doing anything on the patient. So you ready over there? You got good footing?
A patient suffering from a crush injury may not present with obvious signs or symptoms. You must have a high index of suspicion. Certain patterns of injury should cause you to consider the possibility of a crush injury. For example, areas involving the lower extremities or the pelvis.
And talking about crush syndrome and also talking about compartment syndrome, the most important thing in thinking in terms of signs and symptoms is to have the high index of suspicion before the patient exhibits any signs. As unfortunately, as the patient begins to get worse, that's when we start to see, because it's kind of a peripheral injury, and by the time the patient becomes symptomatic beyond what's obvious, the patient's very sick and is having complications. So the big thing is to look at the mechanism, to look at the way the patient presents, and to say this patient is, it's reasonable to consider that they may have a crush syndrome injury or maybe even a compartment syndrome injury. Treat them appropriately, knowing that definitively their treatment is going to be at the hospital, and you just don't want to make it worse or do something inappropriate that would exacerbate or make the injury worse.
The foundation treatment for crush injury syndrome is intravenous fluid. Before any extrication attempts begin, establish an IV and initiate fluid replacement. Normal saline should be used. Because crush injuries may cause the sudden release of potassium from crushed tissue, avoid administering Ringer's lactate, which contains additional potassium.
Okay, Adam, when he moves up out of the way after he gets that secure, we're going to take this board here, and you're going to lift it up, and then we're going to slide it up out of the way after he's ready.
When treating an apparent crush injury patient, begin as you would with any trauma patient. Address the ABCs, maintain the airway, support circulation, and treat for shock. Apply oxygen and provide C-spine stabilization if indicated. Perform a rapid trauma assessment. Keep your focus. Don't get distracted by grotesque or obvious injuries.
A lot of times when we have gross lethal type injuries, we forget that the assessment starts centrally. You know, you have to talk to the patient, you have to make sure the airway's working, you have to make sure that they don't start to have other significant compromise, because even as debilitating and lethal as crushing injuries are, if we lose the airway, if we don't recognize that the patient has got problems in airway breathing and circulation further north of these injuries, we're going to lose them because we got tunnel vision and focused on the wrong thing immediately.
Okay, he's getting a little bit cold. Let's keep him covered up, okay?
Okay.
When we get all these boards off of him, it's going to be a load and go. We're going to get out of here.
Okay. Adam, you want to get up in here and we'll get ready to get this board off.
Signs and symptoms of crush injury are many. A clear indicator would be the large muscle mass that has suffered compression for more than 60 minutes. Other signs or symptoms include subtle skin injury, paresthesias or numbness, which is often mistaken for spinal injury, and can mask the degree of damage. Pain may or may not be present, but often becomes very severe after extrication. The patient may also have a weak, rapid pulse and pale, cool, and clammy skin, clear indicators of shock. You may find that the pulse is absent, or there is a delay in the capillary refill on the distal limb. Swelling may be present, but this is often a late symptom and will occur rapidly after pressure is released.
In a crush syndrome type injury, look for an extremity that is severely damaged, clearly a crush type injury, and immediately start to think about the release of the toxins. What's going to happen is peripherally or even centrally, you might not see big changes, but internally, the potassium is flowing, so you're going to watch for a patient that has irregular heartbeats, starts to show the signs of arrhythmia on the monitor. If the patient is voiding and require the use of a urinal, and you see T-colored urine, you're seeing two things happening here. One, you're seeing that the myoglobin is being processed through the kidneys, and that problem is going to be starting to occur. And on the other side, you'd have to assume that the potassium has also been released, so you watch the monitor.
Can you feel me touching the bottom of your feet? Yeah. Okay, I got good PSMs for right now. Let's get them on the backboard and let's get them out of here.
Critical attention to the patient's crushed extremity is essential to their recovery. Consider immobilizing gently to prevent further injury and to control pain. If splinting, be careful not to bind the extremity too tightly.
For us, when we're putting splints on people, we frequently confuse bleeding control with applying a splint effectively, and we make the splint too tight. And if that's the case and you don't pick that up, you can create a compartment syndrome. So I think those are two things there. That one, our treatment is probably make sure our treatment doesn't create the problem. Recognizing the patient has this problem, because definitively what a compartment syndrome patient is going to need is a fasciotomy, which is where they're going to release the pressure in there so that the muscle tissues can reperfuse and hopefully be able to save that extremity.
Hang in there, John.
Okay, got a headbed ready?
Okay, let's get him
Get you
strapped to the
strapped
board.
down here.
Okay.
Hang in there. Stay with us, bud. Yep.
Okay, over the top.
The biggest thing here is recognizing that a crushing type injury has some very real potentials for causing a threat to limb. Not only threat to limb, but a threat to life, when we talk about these boluses of toxins from the crush syndrome side. So I guess the big thing is to be vigilant enough to recognize, I mean, we beat on mechanism of injury for years, and we've kind of softened that stance to a degree where we go, mechanism of injury is important, but it's part of a big picture. In these cases, significantly, if you didn't take into account mechanism, you might not be getting enough information from your evaluation of the patient to realize that it's developing. So high index of suspicion, rapid recognition of what the patient's needs are.
Built-up toxins have devastating effects on the body, especially the heart. Severe acid overload combined with hypovolemic shock can cause fatal ventricular fibrillation. High potassium levels, hyperkalemia, combined with the acids also can cause severe dysrhythmias or asystole. As soon as possible, apply a heart monitor and obtain a good baseline reading. This will help you monitor for trends and alert you to elevated levels of potassium. Sodium bicarbonate and calcium chloride are used to control hyperkalemia and acidosis, as well as reduce the risk of ventricular fibrillation.
I got a 53-year-old male patient been involved in a crush injury from heavy timber as a result of a forklift accident. He is conscious, mildly alert right now. His blood pressure is 86/60. Heart rate is 140. Radial pulse is weak and thready. Respirations are 28. The sats are 95. Got him on high flow oxygen right now, backboarded and C-collared. Sinus tach on the monitor with no.
Remember your focus. It's important for us to recognize crush injury potential early, because if it's missed, patients are going to have severe complications and problems that we might have been able to get in front of. But not to forget airway, breathing, circulation as we care for those patients. Specifically with crush syndrome patients, we want to remember again, say it over and over again, early aggressive fluid resuscitation, ensure that they get their best shot, and the hospital is going to go further with medications and more fluid. With the compartment syndrome patient, it's important, first of all, probably to think about how these injuries occur. The prevalence, there's really two main causes. We mentioned, say, a fractured bone, but basically what's happening is a blood vessel is releasing a lot amount of blood into a compartment and creating, separating the tissues from their blood supply and interrupting that, so they're going to start to lose that extremity potentially.
Reassess ABCs and be prepared to treat for hypovolemic shock. Keep in mind your patient's age and overall physical condition can affect their response to trauma, as well as compound the severity of their injuries.
Age and general physical condition are generally, with all trauma type problems, a complicating factor or a confounding factor. In shock, for instance, it's a simple thing to know that if somebody's medicated, what we look for as far as developing symptoms of shock might be altered, so the patient's in worse shape than we think. Further, with these types of injuries, older people or people that have illness, their response to the insult might be accentuated or exaggerated, or it might be dulled so that we can't see it. So it can complicate it at many levels. Older people, for instance, that have started to lose muscle tone and soft tissue have these spaces which will accommodate a great deal of blood. And once that happens, it creates a huge pressure. I had a guy years ago, for instance, that fell out of bed in a nursing home. And by the time they got me in there to take a look, his arm had literally was as big as his thigh because of the looseness of the tissues. It was the humeral blood vessel there was able to bleed a great deal in a relatively short period of time. So this guy's in potential for shock on one end, and secondly, for a significant pressure type bleed, which can be causing catastrophic damage to the extremity. So yeah, you know, as through the lifespan as we change, and our tissues change, that can complicate or exacerbate the potential in extremity trauma.
John, how's that feeling?
That still hurts. Jenny, we're almost at the hospital, okay?
Okay.
Crush syndrome is frequently an under-recognized and under-treated medical condition. The main causes of death following a crush injury include hypovolemic shock, hyperkalemia, metabolic acidosis, and acute renal failure. Remember, a patient suspected of potential crush injury should have aggressive and immediate care, and treatments should start as soon as possible during the rescue process. Your treatments can make a critical difference in the outcome of this patient.
Wiggle your toes for me. Thanks. You feel me touching the bottom of your feet? Yeah. Good.
If I was to deliver a pearl here or come up with one thing to take away from these discussions is we can talk about treatments that might help. We can talk about what might definitively fix the injuries. The biggest thing is if we don't catch them, they don't get treated appropriately. So vigilance, paying attention, listening to your patient, listening to the story of the scene. You get to the industrial situation where somebody's entrapped. Look at the size of these monsters people get stuck in. When you're extricating people from vehicles that are entrapped, think about the situation and picture in your mind the insult to that extremity and the potential for injury. If we're vigilant in that sense, we're going to catch what patients are doing. We're going to be more apt to listen to what the patient tells us, even if they're not speaking to us, what that not speaking says to us. All those things, we're going to be more attuned to getting the information the patient needs us to have for them. So paying attention early, being vigilant, and we're going to have our best chance to help people.